Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam. I've been a cardiologist for more than 40 years in the Houston Medical Center area. The focus of this presentation is a statin versus statin plus a non-statin combination for LDL reduction. Let us take a deeper look at where we stand in terms of reducing LDL in patients with high risk features like coronary artery disease, hypertension, diabetes, renal problem. How far we have come in using these drugs appropriately. This presentation is based on this article that was reported in the American College of Cardiology on June 1st by Minnie Verghese and the Christy Valentine team. Of course, I worked at the Methodist Hospital for more than 35 years, so I know Christy Valentine very well. So let's continue with the feature presentation. Let's take, for example, we have a 65-year-old person with a history of coronary artery disease, stent, hypertension, diabetes, and peripheral arterial disease. We know the statins can reduce the LDL level by 40 to 50%. That depends upon whether the patient is on low dose, medium dose, high intensity statins. The target level we would like to achieve in these patients with multiple risk factors is an LDL level less than 70 milligram per deciliter. This patient was on moderate intensity statin. Take, for example, atorvastatin 40 milligrams and maximum guideline directed medical therapy. If the LDL still remains high, what are our options? What are the things that we can do? So let us explore some different options and see which one would best suit the patient in terms of reducing the LDL, in terms of reducing the symptoms related to the drugs, and in terms of improving the risk reduction. Here's a chart showing the various types of statins that are currently available, and the most interesting thing I would like to point out is that only 30% of the people were getting 40 milligrams. So they were not on maximum high intensity statins. Take, for example, atorvastatin, which is the most commonly prescribed drug here in the United States. 80 milligram is supposed to be high intensity statin, which I used to prescribe very frequently in the VA population. But if you look at 38% of them were on lowest dose of atorvastatin. And that is something we need to keep in mind. Not all these patients are getting high intensity statins for reducing their LDL levels, but still a majority of these high risk patients are walking around with LDL levels greater than 100 or maybe 125, where their LDL levels should be more ideally less than 70 milligram per deciliter. Again, with rosuvastatin, which is also another important statin, they are on the low end of the spectrum. 45% of the patients were receiving only 10 milligrams. So the question is, are we treating these patients appropriately? Are we trying to get the maximum benefit from the statins? And if so, what else can we do to reduce the LDL level and minimize complications? To substantiate what I showed you in the previous slide, an European retrospective study of 14,000 patients, approximately 80% of these patients had LDL levels greater than 70 milligram per deciliter on moderate to high intensity statins. Now think about it. 80% of them had levels greater than 70 milligram per deciliter, which means they had not achieved their goal of getting the LDL below 70 milligram per deciliter, despite the fact they were on moderate to high intensity statins. So what are we doing wrong? Are we not giving them adequate doses? But that's not the case, because majority of them were on high intensity statins and still their LDL levels are greater. So what can we do? And this is what this article is going to answer. The questions are, can we increase the statins to the maximum recommended dose? As I told you, more than 40% of the people were getting the low end of the statins. So in patients, especially the high risk patients, if they are on moderate intensity statins, can we increase that to a maximum level? And if so, how much further reduction in LDL we can expect. And I'm going to show you what the results are going to be. It's going to be quite a surprise. The other option is, can we add a second agent? And if you're talking about second agent, what agent are we talking about? Which treatment plan is better? Either increasing the statins to a maximum dose and face all the complications related to the high intensity statins, or do we keep them on moderate intensity statins and add a second drug, or do nothing? So these are some of the options. What would you do? Option 1. We can increase the statin to maximum or high intensity statin if these patients were on moderate intensity statins. But according to this article, it showed that the incremental decrease in LDL level was 5 to 6% by going from moderate intensity statin to high intensity statin. That means you're almost doubling the dose with getting very minimally decrease in the LDL level. So that is not a real ideal choice because, as you know, high intensity statins may be associated with more incidences of myalgia and insulin intolerance. So what can we do? Then option 2, maybe we can add a second agent. So what is a second agent that's available in the market at the present time? We have 4 different groups of agents that are available to reduce the LDL further. The first one is the ezetimibe. The second one is bempedoic acid. Of course, the third one is the PCSK9 inhibitors, namely Evolocumab and alirocumab. Then finally, we have Inclisiran. When we are talking about these newer agents, we have to think about efficacy, availability, cost, and side effects, whether those patients are going to take given all these challenges. Now, let's see how much do these agents actually reduce the LDL level. I'm talking about additional reduction in the LDL levels from what they were getting with the statins to begin with. The ezetimibe is supposed to reduce the LDL by 20 to 35%. I could not understand whether this was an additional reduction or whether it was just related to ezetimibe, but I'm assuming that it's a combination of statin and ezetimibe because that's what the article says. But 20 to 35% reduction in LDL with a combination of statin and ezetimibe seems to be low from my own personal experience. Let us know your comments on this particular aspect. When statin was combined with bempedoic acid, they got 45 to 55% reduction in the LDL level, which is far better than what statins alone can do, which can be like 35 to 40%. Then when we combine the PCSK9 inhibitors, we had the best results of 50 to 60% reduction in the LDL level with this combination. We're talking about moderate intensity statin plus like a PCSK9 inhibitor. Of course, we have challenges with PCSK9 inhibitor, which I'm going to talk about in a minute. Inclisiran had a 50% reduction when it was combined with statins. So we do have an option. You know, we can keep these patients on moderate intensity statins and add a different drug which has beneficial effects in many ways, not just one way. They incrementally decrease the LDL level because they act on different target pathways of the lipid metabolism. While statin targets hepatic cholesterol synthesis, ezetimibe inhibits cholesterol absorption in the small intestine. PCSK9 inhibitors increase LDL receptor bioavailability, and these combined effects provide similar effect of improved LDL lowering efficacy when combined with statins. Here is a little metabolic pathway of various bile acid sequestrants. Bile acid sequestrants. I used to use this a long ago. I don't know. I have trouble even pronouncing it now. Bile acid sequestrants increase bile synthesis, decrease in hepatic cholesterol, which leads to decrease in plasma LDL level. Bempedoic acid and statins, they decrease the cholesterol synthesis, thus decrease in hepatic cholesterol, increase in hepatic LDL receptor that leads to decrease in LDL level, whereas ezetimibe decreases intestinal absorption of cholesterol. And here is the PCSK9 inhibitor, which increases the number of LDL receptors and thus help to reduce the plasma LDL level. So are fixed combinations a better choice? Of course, there are fixed combinations like bempedoic acid along with a statin, which can lower LDL cholesterol effectively and improve cardiovascular outcomes. We also have fixed doses of atorvastatin plus ezetimibe, which has been around for almost 2 decades. Then we have rosuvastatin and ezetimibe and bempedoic acid plus ezetimibe. So these are all different combinations that are available. And here is the one with the statins, namely atorvastatin plus ezetimibe. Then we have rosuvastatin plus ezetimibe. Then we have bempedoic acid plus ezetimibe. So by using these combinations, we can try to bring the LDL level at different metabolic pathways and thus improve the LDL levels, at the same time minimize the complications or side effects related to high intensity statins. And by doing so, we can reduce muscle symptoms, insulin resistance, and may lead to better tolerance and adherence. As far as the PCSK9 inhibitors are concerned, when it was introduced, the cost was prohibitive, but according to changes in 2018 and 19, the costs have come down by 60%, but still they are quite expensive, and we had to get a special permission from the pharmacy committee to get these patients on these drugs to reduce their cholesterol levels. So those are administrative challenges that we face when we have these newer drugs that we want to combine with statins to get the desired result. So ladies and gentlemen, this is a quick overview of lipid lowering drugs. High intensity statin versus moderate intensity statin with a non-statin combination and getting better results from them. Let me know your comments, and thank you so much for watching this presentation. I will see you in the next presentation.